Good day and welcome to the Seeing is Believing Africa Regional webinar. My name is Susan Evans and I'm the Seeing is Believing Project Officer for IPB. And the theme for this Seeing is Believing webinar is integrating eye health into the health system, and we have some fantastic presentations for you today. Thank you all for attending. I really appreciate you taking the time to join us and be part of our Seeing is Believing learning community. And I can see we've actually got 26 people online today from around 10 countries in the region, which is fantastic. If you would like to introduce yourself to the group today, you can write your name and which country you are from in the chat box on the side panel. Also, a big thank you to our webinar presenters. Simon Day, the IPB Africa Regional Coordinator, Alice Mwangi, the Country Manager for Kenya Operation Eyesight, Amos James, the Programme Officer for Health Sight Savers Sierra Leone, and Sally Crook, the Seeing is Believing Programme Manager IPB. Just going to share my screen so you can see the agenda. So the agenda for the webinar today will be welcome and housekeeping notices from me. Then my colleague from IPB, Simon Day, is going to do an introduction to the opportunities and challenges of integration of eye health in the Africa region. Then thirdly, there'll be a presentation on integration of eye health in the Operation Eyesight Kenya Seeing is Believing project by Alice Mwangi. Fourthly, a presentation on the integration of eye health in the Sight Savers Sierra Leone Seeing is Believing project by Amos James. And after the presentations, I will chair a question and answer session. And then finally, there'll be a discussion roundup by Sally Crook. And we'll aim to wrap up by the end of the hour. So firstly, some housekeeping points. So I've shared my screen, so you should be able to view my computer screen through the GoToWebinar window. And I've forwarded you the PowerPoint presentations, and they're in the handout section as well, but each presenter will go through their PowerPoint presentations. Microphones are muted apart from the speakers, as this ensures a better quality webinar. And we aim for this session to be participatory, so attendees will have a chance to ask questions during the question and answer session at the end. So if you have any questions for the presenters, please type them in the chat box. And the chat box can be found on the right-hand panel of your screen, and you can post questions either during or after the presentations. If you have any technical difficulties, e.g. with sound, you can just send us a message in the chat box. But what we would suggest is it's a good idea to close down all other web applications, for example, Google, Outlook, Skype, to get a better quality of call. And if you have headphones, please use those. And I'm recording this webinar and it will be uploaded onto the IPB website, and I'll send around the link as part of the May Seeing is Believing newsletter. And finally, at the end of this webinar, I will be sending you a survey for your feedback. So the theme of this Seeing is Believing webinar is integrating eye health into the health system. So the presentations today will share successful strategies and how they have integrated eye health into the health system and their Seeing is Believing projects. And so we hope that webinar participants will be able to identify strategies which could be used in their projects. So I'm now pleased to introduce my colleague, Simon Day, the IPB Africa Regional Coordinator, to give an introduction to some of the challenges and opportunities of integrating eye health into the health system in the Africa region. So Simon, over to you.
Thank you, Susan. I'm always very happy to be a part of the Seeing is Believing webinars. Right, so thank you. My piece is, as you mentioned, on the introduction to the opportunities and challenges of integration of eye health in the Africa region. Now, as most of you will know, historically, eye health has been somewhat neglected in the development of health systems. This is generally because eye health has been heavily supported by entities outside of ministries of health, such as NGOs, faith-based organizations, and other vertical provisions of eye care. Now, what this has meant is that when developing health systems, there have been cases where it's been deemed that since eye health is already being taken care of, it receives a lower priority. And this has resulted in gaps in systems as far as eye health is concerned. Now, this can be financially inefficient, but it can also be ineffective, leading to failures. For example, screening in diabetics at high risk of diabetic retinopathy, or premature babies going blind from retinopathy. So integration effectively is the combining of one thing with another to form a whole. In this case, that one thing would be eye health, and the other would be the more complex health system in the pursuit of universal health coverage. We all know of the health system building blocks, those being service delivery, the health workforce, health information systems, access to essential medicines, financing, leadership, and governance. And to have an effective health system, all of those building blocks have to be optimally supported. We at IPB Africa have focused on strengthening the eye health workforce by pursuing the goal of having eye health workers integrated at all levels as part of an effective and efficient health system. The immediate objective of this was to integrate the eye health workforce planning into broader human resources for health planning processes at the national level. Now, the way we went about this was through advocacy and influencing policy change. To begin with, there was the development of a message, and to support this, IPB drafted position papers which were produced to provide compelling evidence on critical eye health issues. It also developed policy papers with WHO Afro, such as the core competencies for eye health workers in the Africa region. The next stage was to undertake advocacy at the regional and the sub-regional level to promote the human resources for eye health agenda. To do this, IPB and its members and partners engage with professional bodies, training institutions, and other health organizations to advocate for eye health in a top-down approach. It also aligned with larger interest groups such as the African Platform for Human Resources for Health and the Global Workforce Alliance. That was what we, as I mentioned, what we would call the top-down approach. In terms of a bottom-up approach, we undertook advocacy at the national level to promote integrated workforce planning. And here, we facilitated advocacy capacity building workshops at the national level, which enabled country-level stakeholders to advocate for integration within their own ministries. Now, in terms of this, we had great success, and we achieved the integration of the health workforce in 14 out of 18 countries. And in those final 4 countries, their advocacy campaigns only began last year, and so these are still underway. I think all health sectors, when pursuing integration, would meet with similar challenges. As I mentioned, integration is combining one thing with another to form a whole. So you're looking to integrate into something which already exists, as are others. And probably the most prominent challenge which we faced when trying to integrate eye health at any level, not just human resources, into health systems, was competing priorities. Eye health obviously is very important and tells a good story, but oftentimes whoever you're telling this to, they do buy into your story, but they also their response is that eye health is a disease of morbidity and not one of mortality. So we found ourselves having to compete with other health issues such as HIV, TB, and malaria. So as I said, we come with a good message, but often a very blunt response is, your message is good, but nobody dies from blindness, and we are having to prioritize those other diseases of mortality, and that is something that we still work on. So it really is a key challenge. I think it's also worth noting that integration is not a cure for inadequate resources. It may provide some savings, But integrating new activities into an existing system cannot be continued indefinitely without the system as a whole being better resourced. Another challenge when tackling integration is that it's important to determine what does integration look like. In one of our workshops, we realized integration meant very different things to many different stakeholders. Now, we could look to a working definition of integration. One that says, the definition would be, it focuses on providing the right care in the right place. And for example, integrated service delivery. And the definition of that would be the organization and management of health services so that people get the care they need when they need it in ways that are user-friendly, achieve the desired results, and provide value for money. Now, this is a very broad definition and does not give many clues to what the system that brings this about might look like. So for us at IAPB Africa, when we focused on the integration of human resources for iHealth, we had a sense of what we wanted an effectively integrated iHealth workforce to look like. One element was to have iHealth professionals recognized and reflected in national human resources for health planning. Now, it was one thing to have them reflected in the plans, but another element was to ensure that they were budgeted. It's all very well that they feature, but if they're not properly resourced, then unfortunately, they're going to go no further. Another important element was that the cadres were adequately distributed throughout the country. We see it commonly in countries in Africa where most of the iHealth professionals are clustered in the capital cities. Now, it's all very well to have an adequate workforce in the capitals, but it's really important that they are broadly distributed throughout the country. So that's an example of what I mean by knowing what your integration ought to look like. So human resources is only one piece of the puzzle, and even if we achieve that, it would be necessary for iHealth to feature in the other blocks of the systems in order for the iHealth professional to be effective. As I mentioned earlier, with regard to the health systems, there's health information systems. This would mean having iHealth indicators featuring in the National Health Management Information System, the HMIS. Moreover, they can't just be featured. There has to be an allocation and planning for data to be collected on those indicators and communicated upwards. Access to essential medicines and equipment, they need to be on hand. It's no good having an iHealth professional in a remote clinic if they don't have the equipment and the medicines that they need to undertake their services. Financing is always an issue. It's one that we all come across. All of this that I've just mentioned, it needs to be budgeted. Moreover, it needs to be paid for. So it's critical that iHealth is not just reflected in the plans; it's reflected in the budget, and it receives its funding allocation. And all of this has to be in place for effective service delivery. I would say that the failure to integrate iHealth into universal health coverage and health systems is a matter of grave concern for two reasons. The projections for people affected by sight loss point towards an explosion in prevalence, and the business as usual approach will be ineffective. iHealth is an enabler of well-being and health development and growth. Inadequate services will hamper development and the quality of life. iHealth needs to be integrated in health systems and universal healthcare for efficiency's effectiveness, and the only way to address this problem is at scale. This needs to be at all levels, from primary to tertiary care. All NGOs, governments, and other actors providing iHealth have a responsibility to consider the ways that they're operating and take care to focus not only on programs and projects, but to bring iHealth into the mainstream. The IAPB Alliance is involved with coalitions across our members promoting the right evidence and know-how and advocating for attention to eye health within universal health coverage at the global and national levels. We're constantly seeking opportunities to build partnerships, including with allied sectors, such as diabetes or aging. IPB is committed to working towards integrating eye health within universal health coverage. Thank you, Susan. I'll hand back to you now.
Thank you, Simon. I thought that was a really nice overview of the different elements of sort of the health system in which you talked about, in which eye health can kind of integrate into. So, for example, the HRD, HMIS, essential medicines, but also some of the broad challenges and what integration might look like in different contexts across the region. So, and a good challenge that that you presented to us, that there's something that we need to be thinking about doing. So that's a really nice segue into our first formal presentation from Alice Mwangi, who's going to talk about how she's been, or in Operation Eyesight Kenya, have been trying to do that in their project. So thank you, Simon. So Alice, I'm going to make you the presenter now.
Thank you, Susan, and good afternoon, everyone. In my presentation today, I'll draw my examples from Operation Eyesight, Seeing is Believing supported projects in Kenya, and I will share my experiences in our experience in integrating primary eye health into primary healthcare. In particular, I will draw my examples from two SiB supported projects, and that is the Rift Valley Region Prevention of Blindness project that ended last year in September, as well as Seeing is Believing Kirinyaga Hospital-based Community Eye Health project that is ongoing. And of course, I'll draw most of my example from Operation Eyesight signature model of elimination of avoidable blindness, which we call hospital-based community eye health program. So primary eye care is a vital component of primary health care, and we all agree that, and it includes promotion and treatment of eye conditions that may lead to visual loss, and as well as rehabilitation of those already blind. And therefore, some of the expected outcomes of SiB supported project for us has been to ability to demonstrate tangible results in terms of strengthening partner hospitals to deliver quality eye care services and integrating PEC into primary healthcare, as well as building awareness of target communities, resulting to higher uptake of services. So as I've mentioned, our model has three elements: the one that we have been applying for prevention of avoidable blindness, and that is community eye health, hospital improvement, and disease control. So under community eye health, target areas of intervention are delineated into clusters. We identify surrounding villages based on proximity to health facility with or without eye care services. Where there are no eye care services, we endeavor to establish the services or strengthen those already in existence. The ideal situation is to work with a distance of about 5 kilometers to 2 hours to the nearest eye unit. It is also important to mention that community health workers, commonly known in Kenya as community health volunteers, play a critical role in the model, and therefore selection and training of community health volunteers has to be thorough. With the help of the public health officers at the community department of health, at the county departments of health, our CHVs are selected and trained. and they are trained on door-to-door survey methodology that includes door-to-door screening, identifying people with eye condition and refer them accordingly. We also train them in counseling, follow-up for both pre-ops and post-ops. We also work with the county departments of health to ensure clear referral pathways, and especially where eye care services were initially not available. So the community health volunteers also receive rigorous training on how to conduct awareness creation and in health education activities. And they are well equipped with IC materials. We also apply something we call Participatory Approach Community Eye Health, whereby we sit in the communities and understand their knowledge, attitude, and practice to be able to know how to go about creation of awareness. So under hospital improvement, which is also another element of our model, we are required to, and usually actually do this, to identify service centers, well delineating the target areas of our operation, which must be as close to the target population as possible. We have been successful in lobbying county departments of health to provide space in existing primary health facilities, to establish space to refurbish an existing building to an eye unit. In the absence of such a building of space, we lobby the county government for cost sharing and construction of new eye units. We also lobby for deployment of ophthalmic workers to new eye units, either or support training of new ones to be able to run the facilities that we have established. Please note that the selection of people to be sponsored for training is by the county departments of health. Another area that we focus on as Operation Eyesight is issues around quality. And quality is at the heart of Operation Eyesight, and we work with our partner hospitals to ensure adherence of quality in all spheres. So the other component is on disease control. So the baseline data from the door-to-door survey help us in planning for service delivery and in understanding the knowledge, attitude, and practices of the community we are serving. And this is useful information for production of materials for health education and promotion. So the program support eye care services at static facilities, which give us an edge in lobbying the county government for cost subsidy and making the services affordable. So the support comes in form of provision of consumables, and in some instances, seed funding for eye drops sold at the hospital pharmacy at a subsidized fee. So under advocacy, we recognize the role of government throughout the project cycle, which is critical for the success of our work. And so we involve the relevant government departments in all stages of the project cycle, right from the inception, that is at the proposal development, planning, during implementation, and in monitoring. Eventually, we hand over the project to the government for continuation and support at the end of the project funding. We have been successful in getting county governments prioritize and support eye care services. Some of concrete examples that I can share with you is where we have had some county governments cost share in construction of eye units, increased allocation of eye drugs and other commodities in their pharmaceutical list. Some have even waived surgical fees during surgical camps, while others have agreed to subsidize surgical fees at their hospitals. So patients in Kenya can now also access eye care services through the National Health Insurance Fund. And cataract is free for patients above 65 years of age. Yet we find the majority of people do not have this information. So we are working with our partner hospitals to educate the community on the need to register for the National Health Insurance Fund and also on its benefits. In other areas of advocacy is where we have been able to work with our partner hospitals and managed to include eye health into county integrated plans, which is very critical for future allocation of resources to eye care services. So in summary, the following are the strengths of our model. First, the model responds to Kenya community health strategy that aims to bring services closer to the community by empowering communities with information and essential services. It also recognizes the role of community health extension workers and community-owned resource persons, and that are the community health workers or volunteers. So it's also aligned to Kenya Essential Package of Health, and this is the health system. At level 1, the community level, we target health education and promotion aimed at creation of demand for health services. At the primary level, which is the first care level where clients' health needs are met, and at the county level, which is the first hospital whose services complement primary eye care. So for proper integration all our work is embedded in government health systems and aligned to the National Prevention of Blindness Strategic Plan. So in conclusion, we all agree that integration of primary health care into health system is critical for program sustainability. Thank you for listening to me. Over to you, Suzanne.
Thank you, Alice. I thought that was a great presentation, and I particularly liked the things that you brought out around the fact that, you know, you have been working with the community health volunteers and their importance and the referral pathways, the work that the project's been doing in terms of lobbying the government and working in partnership with them so that, as you said, at the end of the project, it's their services to continue to run. And also doing things like including, you know, aligning with the Kenya Essential Packages of Health and including eye health in the government budget, some really interesting strategies that you've been developing there. So thank you, Alice.
Welcome, Suzanne.
So now I'm going to make Amos the presenter. Amos, so please let me introduce Amos James, the Programme Officer for Health Sight Savers Sierra Leone. So Amos, we're just waiting to see your screen. We should be able to view your screen in a second. Yes, we can see your screen now, Amos.
Okay. From my end here, good afternoon, everyone.
Afternoon.
Yeah, you've had Susan introduced me. I am presenting from the Sierra Leone, Sight Savers Sierra Leone Country Office. You know, so we benefited of a project, Seeing is Believing. The title of the project was a comprehensive eye care in Sierra Leone. So, into business proper. For this presentation, we're looking at integration of eye health into the national health system. And I said we looked at the primary aim. The aim was to ensure participants, for this presentation, to ensure participant understanding of what the successful strategies means for us, what we need to do differently, and to think practically about the changes we need to make and actions we must take to make it happen. So there are 3 key words I want us to understand as we proceed with the presentation: understanding the practicality and the actions which we took to support integration of eye health into the primary health care. For this presentation, we are looking at the definition of integration. my little corner, I said, integration for the purpose of this presentation is the process of incorporating eye care activities into the primary healthcare activities of the Ministry of Health and Sanitation to represent a holistic country health system. What do I mean? The health system has been there. Eye care was not fully integrated. So what we did through the support of this project, we gradually, working with key stakeholders, integrated eye care activities into the primary health care. But then you can't talk about Ministry of Health and Sanitation, SiB, without talking about the health system in Sierra Leone, how it operates, giving you a background. We have 3 tiers of healthcare delivery in the country. We operate at the national, district, and community levels. Of course, all have policies, operational guidelines, and protocols to follow. If we are operating in the national level, district and community levels, there are policies, operational guidelines, and protocols to follow. Integration, of course, we're talking of integration, we said, is actually an evidence from the RAP survey report from 2010 to 2011, which was conducted, which clearly states that lack of awareness about the causes and treatment of eye diseases led to an increased number of blind and low vision people across the country. It's clearly in the report. This was supported by the SiB project, and similarly co-funded by other projects, but it's clearly stand out. It gives us the understanding of what the situation was when the report was out. We similarly had the eye health systems assessment, which further revealed that 80% of the people with eye conditions were living in rural communities and underserved urban slum communities. This prompted the idea to integrate eye care into the primary health care, because by so doing, we are taking eye care to the doorsteps of the people, irrespective of location, place, or where they are. Thus, the need for eye care integration into primary health care to ensure that eye care services are brought to the doorsteps of the affected population, which I already stated. Site savers and partners supported the policy and strategic plan development, training, and capacity building for eye care staff, both at national, district, and community levels. So it will be important for me to emphasize this, that when we got this project, site savers and other partners like CBM who works on the project came together, we fully supported the policy development, the strategic plan development, and building, training, and building the capacity of eye care staff, both at national, district, and community levels. Let's look at the areas of priority areas to follow if you are following my presentation. And let's look at those, let's look at the subtopic, successful strategies on integration of eye health. You know, when you want to integrate, for us in Sierra Leone, the first thing we heard on was to maintain openness and transparency working with partners. You want them to fully participate in, that's what you are supposed to do, and it has been a success. It helps us a lot. We also pre-position partners to do just that. What do I mean? We created an enabling environment by giving them equipment, appropriate human resource training and skills, and making sure that the facilities are there for them to operate and do what they are supposed to do. The process of integration of eye care into primary healthcare was based on the fundamental principle of primary healthcare. That is, we do not reinvent the wheels. What do I mean? But we build on the existing primary healthcare approaches. There are approaches, there are protocols, there are guidelines. As I stated, we build on those to make sure that we integrate eye care. Eye care services we are secondary based, which I will not, before the SiB project, everybody, it was evident that the eye care services we are secondary based. But now trying to bring that back to the primary healthcare level demands creating activities we are embarked on, such as we targeted outreaches, communities for outreaches, community screenings, stakeholder engagement, etc., etc. It was not a standalone thing. It was collaborative. And so it supported the integration fully. Primary health care in Sierra Leone is a community-driven program, like I mentioned. That's what they are for. That's what the primary health care system is for. And site savers were built on it to integrate eye care. The primary health care was there, it was existing, but we build on what was absent to make sure we fully integrate eye care. And then in Sierra Leone, we have the levels through which we provide the health services to the people. We have the tertiary, the secondary, and the primary. It was actually minimal at this stage. When we talk of eye care, was actually minimal, provided minimal tertiary and secondary levels. Site savers, through the funds provided by this project, supported advocacy, networking, and lobbying with key stakeholders of Ministry of Health and Sanitation, the Sierra Leone Parliament or parliamentarians, the paramount chiefs, eye professionals, which actually supported the gradual integration of eye care into the primary health care. It wasn't easy, but we succeeded by reaching and targeting the right people at the right time. Because of what we're doing, working with stakeholders, we are able to localize the training of ONs, ophthalmic nurses, and ophthalmic community health officers. This has actually helped to increase the presence of eye care professionals in all of our operational districts in the country, and even to some communities. And when I talk of community here, we have in Sierra Leone, we have the service provision levels. We have the community health centers, we have the community health posts, we have the maternal and child health posts, and then we have the CHWs working down there. So in most of the community health centers, we have eye care workers that are residents there providing services to the catchment populations. We involved the involvement of key stakeholders right from the inception of the project. From the time we say, okay, we're going to come in with this project, we involved the stakeholders. To the inception, to every aspect of that aspect was we involved key stakeholders. And you know what? We targeted key stakeholders to know who does what, where, and how. These were the strategies we use. We targeted, for example, the National Eye Health Program, key director of Ministry of Health and Sanitation, like which of the directorates? The Primary Healthcare Directorate, the Directorate of Policy Planning and Information, the Directorate of Ambulance and Hospital Services, the Directorate of Human Resource for Health. These were key directorates we work with to achieve our dreams. We collaborated with key directorates at the various levels, both at national, district, and communities. Of course, for national, I talk of Primary Healthcare Directorate, DPPI, Human Resource, etc., etc. For districts, we targeted the district health management teams. And at community levels, we looked at those structures under the umbrella of the district health management team to make sure that they understand what actually we are doing. Effectively, we effectively managed the funding plans of the project by engagements, consultations, and collaborations, regular meetings. We managed that. And then we build understanding and capacity on integration of eye health for Ministry of Health and Sanitation staff, at both from the national, the DHMTs, the primary health care, the primary health units, and the CHWs. The district health management team in the country, we have the ministry itself, where we have the minister, deputy, chief medical officer, and all other directorates. Then under the primary healthcare director, we have the district health management teams, headed by the district medical officer. The district medical officer within his district oversee the operations, eye operations in that district, working with the primary healthcare units, that's the PHUs. And the PHUs are being supported by community health workers who seems to be the volunteers in their various communities to support the identification and referrals of persons with health conditions, not just eye conditions. What were the benefits we enjoyed as a result of this integration? We made sure that we got greater clarity about site savers approach in a specific context of eye care. When you ask in Sierra Leone, about site savers, the first thing they'll tell you is they are the champions for eye business in the country. We are able to clearly articulate more motivating vision for each eye care partner in teams in the country. We developed a clear framework for operational decision making. We have stronger communication of our program, vision, and roadmap for external audiences, partners, other NGOs, and donors. We had a program approach to projects and partners or partnerships we developed. We increased access to eye care services for deprived, excluded, and vulnerable communities. That is by the integration of eye care into the primary healthcare activities and by lobbying through government to deploy eye care workers. We now have a very good geographical coverage in terms of human resource for eye health, providing services in the various locations across the country. As a result of this integration, the program level learning and reporting involving key stakeholders improved. The capacity of eye care professionals and the partners was strengthened and is still being strengthened because we've made sure that in all our health facilities, there are people who are responsible, charged with the responsibility to do a kind of refresher training for the staff. And because of this, it was used as a major tool for advocacy. Advocacy in the sense we are able to lobby with government, working with the disabled organizations to have them being part of the free healthcare initiative in the country, which is a great achievement. The other output we will continue, the project output as a result of the integration. We have 4 indicators into the district health management information system, fully integrated and ensuring that staff at all levels have their capacity built for effective reporting, which we are proud of. We trained, because of this project, we trained 24 ophthalmic community health officers and we trained 29 ophthalmic nurses. Sadly, we lost one during the evils of Ebola. And then we deployed, most of them, or almost all of them, are deployed in rural areas. We had 2 ophthalmic nurses trained as instrument technicians who are supporting the department or clinics with maintenance of its equipment, especially before and after operations. Before, we never had this. Our instruments or equipment were lied, wasting or damaged without being repaired, which impeded the slow, impeded our work greatly. We continue with in-house professional development. Training is being conducted twice weekly for eye care staff in various departments to improve their skills and care for patients, which for me is the key, because once we refresh them, we get information. Once they are empowered by information they get, they can provide the services and provide more care for their patients. And then we train nurses who know on ophthalmic theater nursing to support either the cataract surgeon or the ophthalmologist in the theaters when providing services, that's for cataract surgeries. We revised the primary healthcare handbook to integrate eye care into the PHC. This is in progress. Almost around 70% has been achieved. To support this, a total of 10 community health master trainers were trained on TOT. We use the TOT. 120 peer supervisors successfully trained in 3 districts, 40 each, and 1,200 CHWs trained successfully in 3 districts, 400 each, to support the integration. The training manual, job aids, touchlights, batteries, VHR. Also, we distributed this to peer supervisors and community health workers for use in their communities. So you can see the level this project took us through to achieve what we are to achieve. But in doing all of this, we knew that SiB got another focus. They talked about integration, inclusion, gender, sustainability, partnership alliances, and resource mobilization strategy. So in all what we do, the inclusion, especially for persons with disabilities, we did. The gender, we are gender sensitive in the services we provided. Of course, sustainability, all government, all eye care workers are paid by government. For example, the CHW, they are not paid by government, but they are given some kind of motivation to support what they are doing. We're looking at, in terms of partnership and alliances, we have strategic direction, how we will forward to follow to provide services to catchment populations. We mobilize resources. Because we've done this and we're providing services, we're having flux of people coming to our services, to our centers for services. That is bringing income to maintain kind of sustainability. Other people have heard of our work, and they are coming in to support the work SiSavers do here in Sierra Leone. On the whole, I want to tell you that the integration of eye care in Sierra Leone wouldn't have been possible if we didn't have the support from SiB, Seeing is Believing project. I want to thank you very much for listening, and I rest my case. Thank you.
Thank you, Amos, for that really interesting overview of how within your project in Sierra Leone, you've been working to integrate eye health into the system. And some of the ways that you talk about, building and strengthening the existing system and structures, and using the RAB survey and the eye health system assessment to kind of give you that picture of where the gaps were and where you needed to strengthen. All the lobbying of all the different stakeholders and key decision makers that you've been doing has been really impressive. And as you say, you now have a better geographical spread of eye health workers across Sierra Leone. And also really interesting you talking about that integrating eye health into the health management information system, of which we've already had a question on already. So thank you very much for that overview of what you've been doing. Thanks, Amos. Thank you. All right then, so that's the end of our presentations. So we're now going to have the question and answer session, and I've been reading your questions as they've been coming through, and I'm sort of grouping them per theme. So if you have any other questions for our presenters, please do send them through now. So the first question we've had a question from sort of the same question from a couple of people really. We've got Samantha Nyathi from the Zimbabwe Council for the Blind, and we've also got Cowan Edwards from Zambia. And the question that they have is for both Alice and Amos, which is, how do you cope with the community health workers having conflicting priorities? Do you give them incentives, or how do you do they have other duties, or how do you work with them? So I think if we start with Alice and then go to Amos, just on this first question, how do you cope with the community health volunteers having conflicting priorities? Alice, if we start with you, and then we'll go on to Amos to answer.
Okay, thank you for that question. Yes, I agree that working with community health volunteers can be a challenge, but somehow we have been able to overcome it. One way of doing it is, as I've said before, we train community health volunteers who are already recognized by the health system, and therefore we engage the public health officer to select for us the CHVs whom we have been working with. And the selection criteria is very clear. One of them is that people who are motivated to serve their own community. And then the next thing we do is that when we engage the CHVs at the planning point. That is when before we start our activities. Remember, we train them, and during the training, we do some planning together and set targets together. And these targets, they own them, because we find that if you set targets outside and then come and impose on them, that's when we start having troubles with them. So once they own the targets, and then we are able to, the project is able to facilitate them. We don't call it, it's more of transport, to be able to move from one village to the other, and especially during the screening, which is a door-to-door screening, which can be intense. So we facilitate their transport and also give them some small allowance for their lunch. But we also level the expectation at the planning point, that we tell them, we can't employ them, they are not full employment, and therefore they work within their limits and within their locality, so that we don't stop them from doing their livelihood. And then the priorities, how we manage the priorities, as I've said, during planning, we agree how many days are they going to give us in a week, or maybe 2 or 3 days in a week, so that, or one, depending on the activity, so that we know that the other days they also engage in other health activities, like, for instance, distribution of malaria nets and other work that they may be given by the ministry. Yeah, over to you, Susan.
Thank you, Alice. So a lot of that around the agreements that you make up front with people is so important. Okay, Amos, the same question to you. How do you manage to cope with the community health volunteers having conflicting priorities?
All right. Thank you very much. And thank you to the questionnaire. In Sierra Leone, we are all aware that working with community health workers is challenging because they are not paid. But what the Ministry of Health and Sanitation did, the CHW hub is part of the Ministry of Health and Sanitation. A clear protocol was drafted, reviewed and developed and fully adopted. So what we did here in Sierra Leone, we worked with the hub lead. The hub lead is involved in all of our plannings. So we have the hub lead, and the hub lead is working with the district health management teams. And the district health management team, each of the district health management teams, they have a health coordinator. The health coordinator with the CHW coordinator. The CHW coordinator work with the CHWs in that district. So once we have the planning here with the director or with the hub lead here at the national level, we also work with the director, with the coordinator and the coordinators in the district health management teams who work with directly work with the CHWs. So we are not giving them money because that is already, their minds are prepared. But what they benefit, the benefit of the trainings they receive, knowledge, they are actually acknowledged for the good work they do. A kind of motivation in form of t-shirts, pin-ups and caps are given to them. And it's not actually trying to stop them to do whatever, because here in Sierra Leone, CHWs, they do malaria programs, they do TB, they do other health education promotions and whatever. But we have a time. Like Alice said, we plan together. We're doing the planning. We looked at all of these abnormalities and make sure that there are no conflicts within programs or projects. Now, we're talking about the managing the priorities. That's what I'm saying. We plan together and we look at the timeline of what they are supposed to do at this time, what they are not supposed to do at this time, and we plan together. By so doing, we involve the district medical officers, who actually are the first point of contact for every district providing health services. So they also support through supervision. That's what we do. But that's generally, we support them with trainings, we support them with other means through pin-ups, motivation and whatever, and they are actually happy doing the work.
Okay, thank you, Amos. Great. So that was a really nice overview of some of the ways that you're working, and I think particularly the supervision aspect really came out there as well. So that's great. Thank you, Amos. Okay, so we've got quite a few questions coming through now. So if you do want to ask a question, please do send it across so you can get your question in by the end of the session here. So I have a question, as we've been sort of talking about HR. I've got a question specifically for Amos, which is around the training of the OCOs as equipment technicians. How effective have you found that as compared to training hospital technicians? And would you have a preference for that? A question specifically on that for Amos. And then secondly, while you're thinking about that question, there's also a question around health management information systems and what indicators are you collecting and sending through to the district health management information system? So what are the indicators that are being sent across? And I think that's both for Amos and Alice, because you're both inputting data there. So I think if we start with Amos, the question of the OCOs doing the maintenance, and then you can also answer on the HMAS question, and then we'll come to Alice on the HMAS indicators. And as I say, if you've got any question that you want to ask, then please do. So Amos, over to you, the question about OCOs as equipment technicians.
Thank you very much. Let me start with the ophthalmic community health officers, OCHOs. In Sierra Leone, like I told you, primary health care, we have categories of peripheral health units. We have the community health centers, which is the CHC. We have the community health post. We have the maternal and child health post. Now, when you talk of a community health center, it should be serving a population of 5 to 10,000 people. And for that community health center, it's being manned by a community health officer. Now, we saw the need that if we are to train, let's train somebody who already got a qualification in community health officer, who upgrade. That is, we add the ophthalmic, so ophthalmic community health officers. They are actually in charge to man centers of 5,000 to 10,000 people. Because we are talking of integration and taking eye care to the doorsteps of the people in the communities. Remember in my presentation, I said at national level, tertiary and secondary levels, we had eye care operating. It was minimal, but we had it operating. But when it was actually at the grassroots level in communities, it was not there, not until the project came. So we trained the community health, ophthalmic community health officers to be at those levels to make sure they provide eye care services to the population, their catchment populations. That prompted, and you know what? Because we've done that training, we've increased geographical human resource coverage for eye health, and we are getting more cases being reported and people coming for treatment as a result of the training we've done for the OCHOs. On the side of the maintenance technicians, we had a problem before now. Take for example, slit lamps or ophthalmoscopes. We had several of them lying idle without being used because some are just for minor bulbs, some are just a cable connection. We leave them, we start looking around for equipment to be used in facilities when we have the population growing. So we thought it wise that if we train these people through the help of this project, it will be very important that these people will be providing minimal maintenance to support the work we are doing. And I will be proud to say today that these people are doing very well. There is not a single equipment lying idle in those facilities not being used. So it's a very good thing. Now, talking about the health information management system, we developed 4 indicators. One is the indicator on cataract. 2, indicator on refractive error. 3, indicator on retinopathy. And then 4, we developed indicator on how will I put it? Will I just take it? 4, it will develop indicator on the general eye conditions, because initially it was just general eye conditions. So we looked at all of these indicators: cataract, refraction, retinopathy, and then of course screening, talking about the both primary and secondary levels. We have those in the system. So these are the indicators. We actually looked at what WHO have, the standard, and based on that standard is what we developed at this stage to be in the HMIS system. Thank you.
Thank you, Amos, for covering those 2 questions. And then Alice, for you, the question of what indicators are you including in the HMIS system? Sorry, Alice, please, over to you.
Okay. We work with the Ministry of Health, and under the Ministry of Health, we have the Ophthalmic Services Unit that has a more detailed data collection tool for eye care indicators, ranging from diagnosis of eye problems, surgery, surgical cases, and all that. But now coming to the hospital, the the district health information system form. Unfortunately, in Kenya, I think we have a challenge there that links the district to the national HMIS, because we have only 2 indicators there. That is people with eye problems or conditions and the blind. But as I've said, the ophthalmic services unit, which is part of the Ministry of Health, has a more detailed data indication. Data collecting tool, which actually may not be linked directly to the DHIS, but if anyone needs information on eye conditions or eye problems in the country, then we get in touch with the ophthalmic services unit. We actually get these reports from our partner hospitals, who are also government hospitals. So for the community work that we do, where we engage the community health volunteers, together now at the county level, a bit lower from the national level, we worked with the county records officers, and we're able to develop a tool to help the community health volunteers to collect data. And the kind of data that they collect are people screened and who have been identified with eye problems, people referred, and then they're able to follow up on those who have been received treatment and those who have received surgery. That is at the community health volunteers or at the community level. When you go to the partner hospitals, again, I've said that they use the ophthalmic services unit tool, but now the partner hospitals are able to send this directly to the ophthalmic services unit, but also share with us. So that's how we manage our health HMIS. A bit complicated, yes, challenges, but we are managing.
Thank you, but you're working through them.
Yes.
Great, thank you. And I'd like just to introduce Simon now to also talk a little bit around the WHO Afro creation of the Catalogue of Eye Health Indicators. So Simon, over to you. Sorry. Oh, I think you might be self-muted.
There we are.
Great. Thanks.
Super. Susan, thank you so much. Yes, just to the question on which indicators are being collected, which eye health indicators are being collected, I'd like to mention that WHO Afro has developed what they call the Catalogue of Essential Eye Health Indicators. And this was developed by Afro, so it's regionally specific. There are about 27 indicators in the catalogue. So firstly, the document itself lists the indicators, but then beyond that, it has what you might call an indicator dictionary, which explains exactly how these indicators ought to be met. So it's a really good tool for anybody wanting to develop their eye health indicators within an HMIS. It's a great starting point for that. It's certainly not obligatory by WHO Afro, but it's what they call the essential indicators. So you would probably find the indicators there in that are relevant to the broader eye health infrastructure. The other thing that these indicators relate to are every year WHO requests data, eye health data, which they then compile and post on the African Health Observatory. And if these indicators are adequately populated by the countries, then they would feed into the report that WHO requests on an annual basis. Just another quick note: both of our colleagues from Kenya and Alice from Kenya and Amos from Sierra Leone mentioned the training of health workers in primary eye care. Something else that WHO Afro has just launched is the Primary Eye Care Training Manual, and this is a guide on how to develop how to train healthcare workers in primary eye care. So that's certainly something to look out for. It's both of these documents, the Catalogue of Eye Health Indicators and the Primary Eye Care Training Manual, can be found on the WHO AFRO website. If you were just to type a Google search for either of those two documents, they would come up. You can download them as PDFs, and they're both very comprehensive. And we know that once WHO puts a document out there, it's a very solid piece of information. Thank you, Susan.
Thanks, Simon. I'm just wondering, would you be able to send me a link to those two documents? And if so, then what I can do is I can just email them around the attendees after this session's finished, so that just to make it even easier for everyone.
Certainly, I'll do that.
Brilliant. Thanks, Simon. Okay, right. I'm a little bit aware of time, but there is just one last question that I would like to ask Alice and Amos, which I think is a really lovely question from Patson Tembo from OU Zambia. And his question is to Alice and Amos: how long did it take the project to influence the Ministry of Health to provide the consumables to the new eye departments? And I think really it's a question also around, you know, how did you manage to influence the Ministry of Health? What were some of the kind of your kind of top 3 strategies that you did to sort of try and influence the Ministry of Health to support the work? Because I think that's something that in both projects has come out really strongly around the lobbying that you did with the Ministry of Health and other ministries, and how you managed to get them really engaged with the work that you're doing. So I think, Alice, if we start with you, and then we'll go on to Amos.
Thank you so much for that question. Yes, getting the government into eye health and into the program takes some time, but I think the secret around it is engaging them from the project inception. I think you had mentioned that, and it's not at the point when you're starting the program, but at the point where you're actually drawing the concepts. You know, and then it's also good for them to express the need for support, and then this bring about ownership. So once they express the need for that support, as for us Kenya, we get it through again the Ophthalmic Services Unit, which is a unit that is in charge of ophthalmology in the country. So when we are planning to expand to a new county, we actually approach that unit for guidance. And because the counties who have interest or have expressed interest for support have already contacted that unit, then it becomes easy, because even at the proposal development stage, we start engaging that county so that we are drawing the roadmap together of where we are starting and where we want to end. And we clearly state our responsibilities, both as a partner and as well as the county. And then we engage the county government throughout the project period. And I've said we actually hold regular quarterly meetings to review the program as well as plan for the future. Again, during the monitoring visits, whether in the field or at the hospital level, and towards the project, as we approach the project end, especially as we approach the end of the project funding period, that last 1 year, we do a lot of lobbying and advocacy to sensitize the government that, you know, we are coming to the end of this funding, and you cannot afford to, to lose the gains that we have achieved together, and we have to take over. So it has been a journey, yes, and I must say that for us, we have been successful in many ways in getting the government involved in the program. Thank you, Susan, and the person who has asked the question.
Thank you, Alice. Yes, and it's something that you really stuck at as well. Okay, then Amos, the same question to you, please. How long did it take to sort of get the government on board and Ministry of Health on board, and what were your kind of key strategies to engage them?
Thank you very much, and thank you for the person who asked the question. I will throw the line with my colleague Alice. Actually, there is no definite time, but if you want the stakeholders to actually participate, you have to do what we call a positive consultation and engagement. Continuous positive consultation and engagement will provoke positive answer and positive involvement. That's one. And the essence of project implementation is actually to fill gap where there are so many gaps, but you are coming in to fill a particular gap. But in filling the gap, there is nothing you can do without the stakeholders if you're actually thinking about sustainability. So from the onset of the development of the project, you involve them, you discuss together, you come up with solutions, problems to the solutions, come up with problems and find solutions to those problems. Once they are involved, deliberate actions are taken to address the thing. They become interested into it. They actually becomes the owner. There's ownership provoked and is enhanced. For us in Sierra Leone, we normally conduct. We normally have what we have partners meeting twice yearly. During the partners meeting, Ministry of Health and Sanitation, the partners we work with, other NGOs and IKEA are invited. We sit together, we discuss. But what is paramount here is, because we've involved them, the government here in Sierra Leone is actually responsible to pay salaries of all IKEA workers, irrespective of the project or not. That's a good step because they are involved, they know the importance. Number two, because the stakeholders were involved right from the onset of the project, supported development of the policy, IKEA policy, which was never in existence in this country. Working with them and involving them in every stage of the project, we actually supported, we had the PWDs on board for the free healthcare. Working with them supported the human resource for eye health development. That was actually the reason why the stakeholders, the parliamentarians, the universities, the Ministry of Health will work together to develop a curriculum for the OCHO training and ophthalmic nurses, localized in country. So it depends on what you do at what stage, because if you do not involve them from the onset or onto the closure of the project, you miss out. But involve them, deliberate together, discuss issues together, take decisions together. And like I mentioned today, openness and transparency with them is paramount. So whatever you're doing, you must be open to them. We share with them the project document. They read, they understand, they contribute. So these are the key things which they were to say. There is a time bound to it, let's say 1 month, 2 months, 3 months. No, the momentum of positive response from them will only come when you put positive energy through consultation and collaboration, working with them, engagement, then you will get that and the work will go before. Thank you.
Brilliant, thank you, Amos. And I think that's a great point to end on, talking about be positive as the way to engage with people. Thank you so much. Okay, so that's the end of our question and answer session now. So I'm now going to hand over to Sally Quick, the Seeing is Believing Programme Manager, who does the difficult job of now trying to do the wrap up and sort of summary of everything that's been discussed today. So Sally, over to you. I think you've self-muted, so if you just unmute your microphone, then over to you.
Hi, can you hear me? Is that good?
Yeah, perfect. Thank you.
Great. Okay, yeah, so this is a sort of a wrap-up session, but I really liked in Simon's presentation when he talked about integration and then said that what is normally the issue that eye care projects have to deal with is trying to combine 2 items to form one whole item when you're talking about integration, and this is obviously because of the historical previous vertical programming of eye care services. So we're trying to move away from that old vertical system into being more integrated, or in a sort of more horizontal system with the rest of the healthcare delivery. So I think from the two presentations, I think it was very interesting that we talked a lot in the presentations right down to the primary healthcare level. So it's about the level which is around the communities and where the need is. And for Africa, it is often about trying to engage with the people who have poor vision or are totally blind, and trying to find these people and get them referred to the correct level of eye health service delivery. So I think it was very interesting that this is a really key level to focus on, but as the questions sort of demonstrated afterwards, that even if you're just focused at this level, at the primary health level, you have to engage with all the other building blocks of a health system. You know, as we were talking about at the end there, you know, you're looking at policies so that everybody is in agreement, they all know where their responsibilities are. You're looking at resources. There are never enough resources in any health system anywhere. So you're looking at the resources and who will pay salaries and how will you maintain the enthusiasm of your community health workers or community health volunteers. It's about data. It's both about how you will collect information for your HMIS system, but also what I thought was quite interesting from Sierra Leone was the issue about the RAB and the eye health system assessment. This is often crucial to be able to advocate up to your ministry. You really do need hard data to show what is the level of need and how the service will address the need that is out there. And then that obviously feeds into the staff you need to address that need and the development of curriculums and things. So what I always feel is that eye health projects, you are all so busy because you're all having to work on sort of multiple levels at the same time to sort of get everything up to speed so that you do fit in alongside the rest of the healthcare system. Some of the aspects in the healthcare system have been under development for years and sort of looking at integrating and developing together. But for eye health, this is often quite new and you're having to really paddle like mad to get up to speed and to talk the languages that they talk at the policy and planning level so that the eye care team and the eye care needs are heard at the you know, the planning stage, and everything is in place to deliver the systems. But I think these two projects show that it can be done, and that you know, if you plan well at the beginning, you will get the positive energy that we were talking about at the end, and you will be able to deliver a project that then at the end, as was said in Kenya, you will be able to hand over to the county or to you know, the ministry staff to take on in the future. And we know that the work will be sustainable and that eye care services will be available for those local communities even after the project has finished. Anyway, so thank you both presenters for those wonderful presentations today, and also to Simon to telling us about what's going on at the sort of WHO level around both the HR issues, but also some of the tools that are available through AFRO for the eye care teams now. Thanks, everybody. Thank you.
Brilliant. Thank you, Sally. That's an excellent summary of everything that's been talked about today. And it's great to get that perspective as well. So I'm going to end now by thanking all of our presenters today, Simon, Alice, Amos and Sally, for their comprehensive presentations and responses to all of the questions that came across. And to thank you, all of you who participated. I really appreciate you taking the time to be part of our Seeing as Believing learning community. And also, if you yourselves are working on integrating iHealth into health systems within your project and you want to share with the wider Seeing is Believing learning community, the July Seeing is Believing newsletter will have this as our theme. So if you do want to send me articles, please do, and I can include them in our July newsletter. And I've just one final favour. I'm now going to email you all the Seeing is Believing webinar survey, and if you could please just take 5 minutes to complete it, as your support for these webinars makes them possible and your feedback helps us to improve them. So thank you again, and I look forward to seeing you all at future Seeing is Believing webinars.
Okay, thank you, Susan.
Thanks, Alice. Thanks, Amos. Thanks, Sally, Simon.
Thank you very much, Ali, Susan. Thank you,
Thank you.
Thank you to the speakers and to the SiB team.
Thanks
Thanks,
all.
Simon.
Thanks. Great job, everyone.